welcome to New Life IVF's webinar, Getting to the Heart of Fertility. It's getting towards the end of 2021. 2022 is almost upon us, and what a lot of my patients are thinking about at the moment is what can they do differently next year to help them have a baby if it hasn't quite worked out for them this year. So we'll go through all the issues you should be thinking about tonight. I'm joined by Dr. Nicole Hope, the clinical director of, the medical director, in fact, of New Life IVF. One of the things that I'll talk about tonight is a lot of lifestyle factors. And it's really important to understand what's important from a lifestyle point of view and what's not important and what doesn't help. And one of the things that we know definitely helps is exercise. And for both men and women, if you exercise too little in particular, you will see that it is a little bit harder to get pregnant. For women, it makes it more difficult to ovulate, and sometimes it makes it more difficult for a pregnancy to implant. And on the converse, if you do exercise, you often do see improvements in those things. For men, exercising too much is rarely a problem, but exercising too little can lead to abnormalities in sperm count, sperm number, and sperm function, and even erectile dysfunction. So we do encourage men to exercise. For women, what we recommend is any amount of moderate exercise is always going to be beneficial, and probably where the sweet spot in terms of reward for effort is at around the 2 to 4 hours per week mark. And women who have higher BMI get even more benefit, and they get even more benefit from exercising at a higher intensity and for longer periods of time than 2 to 4 hours per week. Like I mentioned, for men, we see benefits from 2 up to 10 hours of exercise per week, which is rather a lot, a little bit more than I have time for and most of us have time for. One thing that you've got to be careful of, the one form of exercise that seems to worsen sperm parameters rather than improve them, is cycling. And that's probably because of overheating the testicles, leading to a reduction in sperm quality. So cycling is probably best avoided. Like I mentioned, erectile dysfunction is prominent in men who don't exercise. And sometimes you've got to be clever with how you motivate men. And one great way is to start suggesting that they might have difficulty having an erection if they don't follow a certain pattern of behaviour. So this is just a little fact to pack in your back pocket if you want your partner to do something like exercise. We all know that smoking is bad for us, and a lot of the effects of smoking are things that we come across later in life, like lung cancer and heart disease and things like that. But smoking undoubtedly affects your fertility, and we see reductions in quality of eggs. We see DNA damage within eggs and sperm with smoking. And probably the number one thing you could do in terms of effectiveness, that's from a lifestyle point of view, would be to reduce your smoking and to stop smoking. And in non-smokers, if you consider that women who don't smoke have an approximately 80% chance per year to get pregnant, that drops down to about 30% if you're a smoker. So massive gains to be made by reducing your smoking. And we see similar results in men as well. Weight optimization is another obvious one. And we know that if you're a very low weight, which is admittedly less of a common problem, it can make it harder for women to ovulate. So normalizing weights for underweight women might make them more likely to ovulate and ovulate in a timely way. And we know that increased weight can affect ovulation also, together with affecting how an embryo can implant in the lining of your uterus. And we've got very good data also that men in particular being of low weight can affect their sperm parameters, but also being overweight. So if we look at this graph, it shows us that women who are of a normal BMI, so BMI is the body mass index, and it corrects for your height as well as your weight. And if you are in the overweight range, we do see a significant drop in annual pregnancy rates, which is what this graph is showing. Similarly in men, as I mentioned, quite a drop-off in chance of conception for men who are underweight, which is interesting. You have to be, I would consider men in this sort of group here a fairly normal weight. Once you get to around a BMI of 27.5 to 30, we do, and above, we do see drop-offs in natural conception odds in men. Alcohol, we talk about rather a lot, and whilst I must admit I do tend to preach abstinence, the question I'm often asked, what about one drink? Does that make any difference? And it probably doesn't actually. And this is a study from published about 5 or 6 years ago that looked at the chance of a woman conceiving based on the number of standard drinks of alcohol she had per week. And as you can see, you get very, very similar pregnancy rates until you reach about 7 or 8 drinks per week. And then once you go beyond that, we do see a reduction in pregnancy. So I think I'd probably change my advice and say, look, 1 or 2 drinks every now and then is probably not a big deal. And if you go back to my advice earlier, I've just told you to enjoy Christmas. So I think you can comfortably have the occasional drink and not worry about it affecting your fertility. So what we really want you to do next year is to take yourself perhaps from the lesser version of yourself and get the absolute best out of your physical conditioning, and that will absolutely improve your chances of having a baby. I get asked a lot in my clinic about what supplements should be taken to improve pregnancy rates, and I must admit there's no single supplement, there's no combination of supplement that will give you the gains that I've just described to you from all of those lifestyle factors. The difficulty, of course, is that most of the things I've just told you about are not necessarily easy. They do take persistence, they do take a lot of effort, and they are hard to achieve, I'm not going to lie. Whereas taking a supplement is a relatively easy thing to do. But I don't think there's really a role for supplements unless you already look like, who was that guy? Was that Hemsworth, Chris or Liam? Chris. Yeah, unless you're looking like Chris Hemsworth, you probably, if you are Chris Hemsworth, then you can start thinking about supplements. But up until that point, I think just look after diet and lifestyle. The one really important supplement is folic acid, of course, in women, not because it improves pregnancy rates, but because it reduces the rate of neural tube defects, which is a particularly nasty fetal abnormality, quite preventable if you're on folic acid at the right dose. Diet and fertility also is probably nibbling around the edges. I know, look, obviously a good healthy diet will assist in weight loss, but beyond that, on an individual scale, I'm not sure that diet makes a massive difference. But if you had to ask me what is advantageous, then eating fish twice a week seems to be, consuming good quality oils, and I'm talking about olive oils and things like that, and having a high intake of vegetables. Again, if you look at the list of supplements, they're sort of all trying to replace things that you would otherwise find in a healthy diet. The things that are usually bad are trans fats, so they're sort of pre-produced deep-fried foods, generally are high in trans fats, and they're unfortunately no good. They're often very delicious, but sadly no good. Sugar, I bang on about sugar all the time. My patients are sick of hearing me talk about sugar, but unfortunately that should really be cut out. And then there's sort of other things that don't seem to make much difference, and dairy's neither good nor bad. Caffeine, 1 or 2 coffees a day does not make it harder to get pregnant. 4 or 5 probably increases the rate of miscarriage, but 1 or 2 is certainly fine. And then red meats and chicken and things like that are quite neutral, make no difference whatsoever. So aside from all those big ticket lifestyle items that I mentioned, probably making sure you're having sex frequently enough and at the right time is probably the next most important consideration. I've said when, where and how, couldn't care less where, but the when and the how is relatively important. And this little graph here shows what we often call the fertile window. And if you look at this little line here, it talks about your chance of of becoming pregnant if you have sex on a particular day of your cycle. Now, what it's talking about is the day of your cycle relative to when ovulation occurs. So being able to interpret this really does rely on you knowing when you're ovulating, but we'll get to that in a minute. But what it shows us is that the highest rate of pregnancy is actually 2 days prior to ovulation, which might be the opposite to what most people would be expecting. But what you really want is the sperm to be in there and ready and to be able to find the egg as soon as it pops out. So highest day where you'll have your highest chance of getting pregnant is 2 days prior. And as you can see, interestingly, 4 days prior to ovulation is better than the day of ovulation. So you really need to be having sex comfortably before ovulation occurs. So for women, what does that mean for women with a 28-day cycle? It means that their most fertile day is probably around day 12 of the cycle and for a few days before. So rather than day 14, which is the time of ovulation. So ovulation typically occurs about 14 days before your next period. Where things become a little bit difficult is if you have irregular periods, and Nicole will talk a little bit more about that later. But also, what if you have a different cycle length? What if you have a 30-day cycle or a 32-day cycle? Well, what we do in that instance is we, again, count backwards from your normal period length. So if you have, for instance, a 25-day cycle, so a little bit shorter, we'd expect that you probably ovulate about day 11. So that means that you should be having sex on around about day 8, day 10, and day 12. Conversely, if you have a slightly longer cycle, 32 days, we would expect ovulation to be occurring on around about day 18 of your cycle. So therefore, by having sex on day 15, 17, and 19, you're covering all bases. You're comfortably hitting those really fertile days before ovulation. You're also doing day 19, because what if you ovulate a little bit late this month? You never really know, so it's probably good to do that as well. The frequency is something I'm often asked, and people often assume that having sex every day is better, but it does get a little bit, it can get a little bit tedious, get a little bit exhausting for many of my patients. So if you look at the top line there, we don't see a huge difference in pregnancy rates, whether you have sex every second day or indeed whether you have, every day or every second, very, very similar. So I generally recommend every second day is fine. A lot of people ask about lubricants and things like that. There's a couple of sperm-safe lubricants there, so I'd make sure you're using those if you need to. And position, there's lots and lots of things that I stole this slide off a colleague of mine, Dr. Hugo Fernandez, but all that you really need to know is that position doesn't matter in the slightest. Female orgasm doesn't matter in the slightest, although I definitely shouldn't say that. It's very important for all sorts of other reasons, and position really doesn't matter. Do whatever you like. So they are just a nice little summary of the things that you can control in terms of helping yourself have a baby. I now invite Dr. Nicole Hope to come and talk to you about what a good fertility specialist can offer, and she is certainly a good one, so well worth listening to. I'll be back later.
So I'm going to talk to you about some of the investigations that your fertility specialist can organise for you. So I guess the first thing is, when should you actually be seeking assistance? Generally, we sort of define infertility as being 12 months of trying and not getting pregnant. And that will, for most people, about 85% of people will be pregnant after 12 months. And so we'll have about 15% of couples who still aren't pregnant after a year of trying. So if you are young and otherwise healthy and having a regular cycle and have no known cause for infertility, we generally would say it's good to try at least a year, and then that's a good time to seek advice. However, there are some situations where it's good to seek advice a little bit earlier. So we would say if you are over 35, that might be a time to seek advice earlier. It doesn't mean that if you've been trying for 6 months and you're not pregnant, then you have to start IVF straight away. But it's good to at least start doing all the investigations, confirm ovulation, check the sperm, check your tubes are open, start that whole process so you don't get too delayed with your fertility. There can also be other reasons to seek help earlier. Sometimes you might already know that you have a problem with fertility. That could be that you have issues with intercourse, and that could be from the female or male perspective. If you have a really irregular cycle, you might not be able to time when you're ovulating, or you may not actually be ovulating at all. And obviously, we don't want you to try for 12 months if you're not actually ovulating at all. You're better off seeking help early and hopefully getting some medication to help with ovulation. Some people will know that they have a low egg number. Maybe they've had chemotherapy before, or they've had some surgery on their ovaries, or they have had tests to look at their ovarian reserve and they have been told they don't have a lot of time. And again, that's the time to seek help earlier as well. Likewise, some men may have had issues before with their testicles or have infertility with another partner. Maybe they've had surgery on the testicles, or they've had a testicle removed, or they've also had chemotherapy or something like that that could affect the sperm count. So yes, we generally suggest a year, but if you are older or if you have a pre-existing problem, it doesn't hurt to seek help earlier and at least get that ball rolling and some of the investigations started. So in terms of evaluating men, it's pretty easy. We start off doing a sperm test, and what we're looking for on the sperm test is the number of sperm, the swimming, and the shape of the sperm. And if you go to a specialist reproductive lab, sometimes we'll also check things like sperm antibodies as well. If the sperm test comes back abnormal, we don't just go, that's it, it's the guy's problem. We often will suggest some lifestyle factors that, like Chris has already discussed tonight, to see if we can try and improve the sperm. We know that every time a man does a sperm test, you're going to get a different result. And we know that there are external factors that can affect a result on a particular day. If a man has been unwell, like a cold, flu, gastro, these are things that can have a negative effect on the sperm. And potentially, if you wait and repeat the test after 6 weeks, you will see an improvement in the sperm count. So if we do get an abnormal result, the first thing we do is always repeat the test after a period of time to allow the testicles a little bit of time to recover if they have been exposed to something like a virus or infection. In terms of evaluating the female, there are a few more things we have to check. We have to look for, assess for ovulation. So as Chris was saying, typically we expect women to ovulate about 14 days before their period. So there is a test we often do called a mid-luteal hormone test. And basically that's checking all the reproductive hormones, in particular progesterone, to confirm that ovulation has occurred. When a woman ovulates, her progesterone hormone rises and it reaches a nice high level about a week after ovulation. Some of you may have heard about the day 21 progesterone test, and in someone who has a 28-day cycle, who is ovulating on day 14, we would expect them to have a peak progesterone level around day 21. But if you're someone who has a 35-day cycle, you may actually only be ovulating on day 21. And so if you do a day 21 progesterone test, your progesterone is going to be low, you'll get told you're not ovulating. But you probably are ovulating, you're just not ovulating until day 21. And so when we say a mid-luteal test, what we're talking about is doing this progesterone test a week after we think you've ovulated. We're also going to do some basic blood tests for you. This is checking other hormones like your thyroid function. We know that if your thyroid function is overactive or underactive, that can have a negative effect on conceiving and might also contribute to miscarriage. So it's really important that your thyroid function is well controlled before you conceive. We'll also check various infections, hepatitis, HIV, make sure you're immune to rubella and chickenpox, look for some other infections in the urine, maybe chlamydia and gonorrhea. These are all things that we want to make sure are all sorted out before you conceive as well. We are going to do various tests to assess your ovarian reserve, which basically means how many eggs you have left. And I've got a slide coming up and I'm going to talk about that a bit more. We often will do an ultrasound to assess your pelvis and your uterus and ovaries and anatomy. We might talk with you about assessing your fallopian tubes, and sometimes we might talk about even doing a surgery, in particular a hysteroscopy and laparoscopy. So ovarian reserve tests, as I mentioned, these are tests to see how many eggs you have left. We don't actually get a number like you've got 529 eggs left, but we want to get a feel of how many eggs do you have compared to other women your age, and are you at risk of running out of eggs earlier than what we would expect? So the number one test for assessing ovarian reserve is AMH, which is anti-Müllerian hormone. And this is something you can have tested on a blood test. It can be done anytime in your cycle, and it's quite a reliable result. When you get your result, we then have a little graph where we can look and compare you to other women your age to see how many eggs you have left. Age is also a pretty good test of ovarian reserve. It is normal that as women get older, they have less eggs. So when we have an older woman, we would expect that the number of eggs is going to be less, and that's normal. Antral follicle count is referring to an ultrasound assessment of the ovaries and counting how many follicles you can see. With that ultrasound, it does only tell you how many follicles there are in that particular month. It doesn't give you an idea about your long-term egg supply, but often the AMH and antral follicle count will correlate. The final one I've got there is doing a day 3 hormone check. When I started out doing training, this was a very popular thing to do, and I know a lot of GPs still do this, but I think the AMH has kind of superseded that test, and I must say I don't order it anymore. Your FSH and LH, if you have a low ovarian reserve, these can be elevated on day 2, day 3 of your cycle, but it is really variable. And so some months your FSH and LH can be normal, and yet you can still have a low ovarian reserve. And that's why I prefer to just do an AMH test, as it's not as variable from month to month. If we did see that you had a low ovarian reserve, that might be another reason, as I mentioned earlier, to get the ball rolling sooner rather than later, because once you have run out of eggs, unfortunately, we can't get your eggs back. So we need to make sure that you are getting pregnant while you still have eggs. The next investigations are investigating the uterus and the tubes and the pelvis. So usually you will get a pelvic ultrasound. Initially, we are doing an ultrasound to look at your anatomy. We look at the uterus, the lining of the uterus, the endometrium, make sure it's a good thickness. We're looking at the ovaries. We're seeing, are there any cysts? Are there polyps or fibroids? Anything physical that might actually have a negative effect on an embryo implanting. We can sometimes do a special ultrasound where it's a bit like having a pap smear done, and we put a little bit of fluid into the uterus and watch the fluid go through the tubes, and that's a way we can also confirm that the fallopian tubes are open. You can also confirm the fallopian tubes are open by doing an X-ray, and that's called an HSG. And that might also sometimes show up some polyps and fibroids. But an ultrasound will pick up those things as well, plus probably some extra things that the X-ray won't see. This little cartoon down the bottom of this slide is showing doing this ultrasound or X-ray version of checking the tubes. So they put a little tube in your vagina and into your cervix, and then they inject some fluid in and watch to see the fluid go through the tubes. So the picture on the left, you can see the white of the fluid has gone through both of the tubes, and therefore confirming the tubes are open. But if you look on the picture on the right, you will see that the white has only gone through one tube and it hasn't gone through the other tube, and that's how we know that that tube might be blocked. Sometimes, rather than doing an ultrasound or X-ray to assess the tubes, we may actually do a surgery. And usually if we are doing a surgery, we do what's called a hysteroscopy, and usually we do that together with something called a laparoscopy. A hysteroscopy, not to be confused with a hysterectomy, is where we put a camera into the uterus and have a look inside the uterus. And that's the best way to have a look for things like polyps, fibroids in the uterus, scar tissue in the uterus. We usually do a little clean out of the uterus, which is called a curette, and we send that tissue off for testing. Sometimes when they have a look at that tissue under a microscope, they may see some problems that we haven't even expected. For example, some infection in the lining of the uterus, or maybe some irregular cells that would stop an embryo from implanting. The laparoscopy is keyhole surgery, which is done on your abdomen, and we put a camera through your belly button and we look into your pelvis. We can assess the tubes. We do it actually the same way as the ultrasound or x-ray, except instead of using an ultrasound or x-ray to see the tubes, we are actually physically looking at them. It's the gold standard for checking the fallopian tubes. Sometimes the x-ray or ultrasound might give some false results due to a variety of reasons, and usually we get very clear results at the surgery. We also get to look for things that might be missed on ultrasound, for example, endometriosis, and if we see that, we can actually physically remove that at the time. So you do have to weigh this up against risks of the surgery. It is a day procedure, which means you come in the morning and go home in the afternoon. But nonetheless, there are still some risks of the surgery, and that's something you need to speak about with your doctor. So what if you've had all those tests and everything is looking good? What are your options next? So there could be ovulation induction, which means taking medications to assist with ovulation, and that could be tablets or it could be hormone injections. IUI, which means insemination, and that's where we get the sperm and inject it into the uterus. IVF, and then finally ICSI. ICSI is actually IVF, but it's a specific IVF where we inject sperm into the eggs. And we do that when we are concerned about the sperm quality. So with ovulation induction, Clomid and letrozole, these are two of the tablets that we can give to help with ovulation. This is particularly helpful in women who don't ovulate regularly. So for example, women with polycystic ovarian syndrome. With women with PCOS, we can get about 70% ovulating regularly on one of these medications. It's usually just a 5-day course of tablets that you take at the start of the cycle. Sometimes we have women who don't ovulate on the tablets. So for example, the 30% who don't respond, maybe they are ovulating on the tablets but still not getting pregnant. Or maybe they have a different ovulation problem that doesn't respond to the tablets. And so in those patients, we might swap from the tablets to injections, and these injections are follicle stimulating hormone. The injections are in like a pen device, a bit like an EpiPen or insulin pen. We usually teach you how to administer that to yourself, and you give yourself a little injection in the tummy every day. You are usually doing these injections for about 10 days, and then you have a final trigger injection to make ovulation happen. Usually you can get most people ovulating on the injection. So if the tablets haven't worked, the injections are a good next step. A lot of patients ask about intrauterine insemination, and this is where we inject the sperm into the uterus. It's generally patients like the idea of this because it's not as invasive or as expensive as IVF. The reality is that the success rates are not that flash, and there probably are less people who will benefit from insemination. So it can be helpful if you have sperm abnormalities. It's going to help more of the good sperm get into the right place at the right time. It's very helpful if there are issues with sexual intercourse that you're not even managing to have sex at the right time. Obviously, if you are needing donor sperm, insemination is the mainstay of donor sperm treatment. And sometimes when couples are doing ovulation induction, they may also do insemination just to make sure everything's lining up at the right time. But as you can see down in the orange at the bottom of the slide, the pregnancy rate is only about 10 to 15%. So even after a few goes of insemination, a lot of couples will unfortunately not be pregnant. The next and final option in our arsenal is IVF. For those of you who don't know anything about IVF, basically you are taking hormone injections for about 10 days. We start at the start of the cycle, day 2 to say day 12. We then do an egg collection, which is taking the eggs out of you, and that's usually done around day 13. On the same day we take the eggs out, we get sperm and we put the eggs and sperm together to form embryos. We then grow these embryos in the lab for 5 days, so say from day 13 to day 18, and then we bring the woman back in and put an embryo back into her around day 19. And then the pregnancy test is about 10 days later. So basically you start with your period and you're doing your pregnancy test at the end of the month. So it takes the same amount of time as if you're trying naturally. So to talk about the egg retrieval, a lot of people do get a bit worried about that. This picture here is showing how we actually do it. We have an internal ultrasound and it has a little needle on it. And we use the ultrasound to see where to put the needle, and we can put the needle straight through the vagina into the ovary, and then we retrieve the eggs. And we do that on both sides of the pelvis to access both ovaries. It generally takes about 10 to 15 minutes. You will all be very relieved to know that we do put you to sleep for this. It is a light anaesthetic, but nonetheless, you should have no memory of it. You'll definitely need that day off work, and a lot of women also take the next day off as well, but some women are recovered enough that they can work the next day. In terms of putting the embryo back, this is just like having a pap smear done. And so most women will actually do this awake. However, if you are someone who has struggled with pap smears in the past, you can have an anaesthetic to have your embryo transfer as well. We use an ultrasound to make sure we're placing the catheter in the exact right place so that the embryo has the best chance to implant. So that is my very quick rundown of an IVF cycle and things that your fertility specialist can do. And so now we are up to questions, and I think Chris is handing me a list of questions that we have so far. So I'm going to start with the first few. So the first question is the importance of good quality foods on implantation, foods to avoid and foods to include. And I think Chris probably covered that a bit earlier, but it really is common sense stuff. There's no magic food, but obviously I think everyone remembers those food pyramids from school. Basically, we want more of the fruit and veggies, lean meats if you eat meat. If you don't eat meat, that's fine. It's just if you do eat meat, go with lean meats. And trying to avoid less of the stuff that we know is bad, the saturated fats, the processed foods, the sugars. So no magic food, just keeping in mind that pyramid. Obviously with Christmas coming up, we do get lots of challenges and there are lots of yummy foods around that we don't normally eat. Like Chris said, enjoy your Christmas. It's okay to have some stuff we don't normally eat, to have it on Christmas. Just don't eat it every day. Next question is, what are some of the causes of recurrent implantation failure, and do I recommend a laparoscopy? So look, there are many causes of recurrent implantation failure, but with regards to a laparoscopy, I think if you haven't had one of those before and you have had several embryos transferred that haven't implanted, then definitely a laparoscopy is a good thing to start with. As I mentioned before, we can assess for endometriosis. Endometriosis doesn't typically show up in ultrasound, and so sometimes you may not actually know you have endometriosis until you have a laparoscopy. There are also some subtle things that you may not detect until a laparoscopy. So I mentioned before, when you have a curette, we might find some infection in the lining of the uterus. When we assess your fallopian tubes, we may see that they might be open, but they might be dilated and swollen, which is called a hydrosalpinx, and then that might be something that also has a negative effect. So I think there are lots of good things, well, not good things, but there are lots of things that can impact on implantation that we would only find when we do a laparoscopy. So as I said, if you haven't had that done, I think that's a good thing to speak to your specialist about. The next question is, can a laparoscopy and hysteroscopy affect reserves in a bad way? I think we know that any surgery on the ovaries can potentially have a negative effect on your ovarian reserve. In the past, we used to do a lot of something called ovarian cautery. So for women who had polycystic ovarian syndrome, we might do some burning of the ovaries to reduce the number of eggs, and that might help with ovulation induction. And that was a way to ovulate without taking medication. I must say, I haven't done that for several years now. Ultimately, if you burn the ovaries, you are going to reduce someone's egg supply. If you have a cyst on your ovary that is potentially problematic, you do need to have that cyst removed. And we know that when you have a cyst removed, that can also damage your ovaries and reduce your number of eggs. But you have to weigh up with your specialist what's the benefit, what's the harm of leaving the cyst there versus the harm of doing the surgery and removing the cyst or whatever you need to do. So I think the thing is, yes, it is possible you could have some damage to your ovaries, but usually it's happening when you're actually doing something to the ovaries. And as fertility specialists, we really try and have a hands-off approach to doing anything to the ovaries. And usually we're only operating on or near them if we really think that that's a problem that would have a negative effect on fertility. The next question was asking about costs involved with egg freezing. If you go to the New Life website there and you look under the costs, you will see that we have some costs there for egg freezing, the cost per cycle. But basically with egg freezing, there's the cost of the IVF. We do have some costs for ongoing freezing of the eggs, and I think that's about $225 every 6 months for keeping eggs frozen. That's just a flat fee, so if you have 10 eggs or you have 30 eggs, the cost is still $225 every 6 months. And you will get your first bill for that after 6 months of having your eggs frozen. So I think that's pretty much on the website that you can have a look at. Chris is now going to answer some more questions, and I will let him come and take over.
Thank you, Nicole. So our next question is, does a fish oil supplement increase fertility? And if so, what dose? Look, I think there's not a lot of certainty around whether fish oil does make a difference to your fertility rates. I think we know that eating fish twice a week probably does, but again, we don't know that with any great certainty. So I'd be reluctant to say that it definitely makes a difference. Fish oil certainly doesn't hurt, so it's not going to be a negative. So if you feel confident taking it and you would like to take it, absolutely. And as for a dose, I would just follow the instructions on the bottle for fish oil. How do you keep your progesterone levels down to ensure you can have a fresh transfer rather than a frozen one? So what this question's about is that sometimes during every IVF cycle, in fact, we do measure progesterone levels as well as other hormone levels during the stimulation phase of the cycle. So that's in the time that you're having injections to stimulate your ovaries up until the point of the egg collection. So that's the stimulation phase. During that time, we do check progesterone levels. And one of the reasons we do that is that an elevated progesterone level in that time sometimes causes the lining of your uterus to begin maturing and getting ready for pregnancy too early. And if it starts maturing and getting ready for pregnancy too early, by the time we put an embryo inside, it might be that the embryo is not as receptive as it should be. So for that reason, we do check progesterone levels. And when we see an elevated progesterone level, it doesn't mean that if you did do an embryo transfer, you won't get pregnant. It just reduces the likelihood a little bit. It's enough for most people to consider that freezing their embryos, letting their lining recover, and doing an embryo transfer during either a natural ovulatory cycle or during an HRT cycle might be beneficial because it has slightly higher pregnancy rates. So that's just a little explanation of what that question's about. So I guess the next but what the question's getting at is how do you reduce the progesterone level or prevent it from starting to spike early. Tends to be more common during an antagonist cycle. So if you're using orgalutran or septritide to prevent ovulation, we do see progesterone levels rise a little bit more commonly in that group. And for that reason, sometimes a long cycle or a downregulation cycle might be better at preventing progesterone from elevating. But I guess by extension, I would say, should we really be too worried if your progesterone is rising? If ultimately you're getting really good quality embryos, if they're frozen well in a good IVF laboratory, you're going to get really good thaw rates and you're going to get really good pregnancy rates with those frozen embryos. So I wouldn't be too devastated if you're finding it's difficult to get a fresh embryo transfer. But I can understand sometimes it is a little bit... can be a little bit disheartening if you're missing out on a fresh embryo transfer and then you're having difficulty with your frozen embryos. How much alcohol can I drink or not drink when trying to conceive? So we had that beautiful slide earlier on. I would say, a few drinks a week, 3 or 4 drinks per week, spread out across the week, probably not all at once, is probably safe for men and women. If you wanted to, if you wanted to absolutely everything you could do to try and conceive, I think deep down in my heart of hearts, it's probably better to not drink anything at all. But I think this time of year, I'll go with that study from 2016 that says it's okay. So I'm now going to ask Nicole up to answer a few more questions.
So I have the question, does having PCOS make you have more abnormal embryos, especially if you're a lean PCOS? And I don't really think there's any particular evidence that having PCOS leads to more abnormal embryos. We do know that if you have PCOS and you are overweight, or you also have diabetes or glucose intolerance or insulin resistance, these are things that can have a negative impact on the embryo implanting and might lead to miscarriage as well. As Chris was talking earlier about your weight and BMI, if you have PCOS and you are overweight, it's really good to try and focus on some slow weight loss and get your BMI back into that normal weight range. If you have PCOS and you have some glucose resistance or insulin resistance, it's good to see if you can bring that back to normal with dietary changes, or if not, you may want to consider going on a medication like metformin, which can be really helpful for maintaining your blood glucose levels. But I think if you have PCOS and you are lean, so you're not overweight and you don't have any evidence of diabetes or insulin resistance, I don't think you have any particular increase in abnormal embryos, or in fact any increased risk of miscarriage above other women your own age. Next question is, when should I stop taking coenzyme Q10? I guess I would say potentially keep it going until your pregnancy test. If you are someone who has a lot of frozen embryos and you know that if you are not pregnant, you have another embryo that you can put back, you may feel happier to stop that earlier. But if you say only have one embryo to put back and you know that if you're not pregnant, you might have to do another stimulated cycle, maybe you would keep the coenzyme Q10 going until you have a definite result from your pregnancy test. Having said that, if you're having side effects from the coenzyme Q10, or you're not tolerating it, or you forget to take it, it's not the end of the world. Next question is, does acupuncture improve embryo transfer success? This has actually been something that has been really well studied, and there are lots of really good trials in IVF patients having acupuncture. Some studies did show improved pregnancy rates in women who had acupuncture. Other studies didn't show much of a difference. But importantly, no studies ever showed that doing acupuncture made pregnancy rates worse. So we know that it is safe. And for some people, they actually do find the process quite relaxing, and it's a way to manage their stress. So I think if you have a needle phobia, don't go out and get acupuncture. But if this is something you do find relaxing, I think anything you can incorporate into an IVF cycle to help you manage stress and stay on top of things is going to be really helpful for your just general well-being, and hopefully also for your chance of pregnancy as well. So I think we might be at the end of questions. So I'm going to hand over to Chris.
Thank you very much for joining us tonight. We have enjoyed putting the presentation together. We wish you all a wonderful Christmas, Happy New Year. We hope that 2022 is the year of the baby for you. We will be back next year with more webinars. Nicole and I will be back at work. In fact, we're still working up until Christmas and potentially well into the new year as well. But it's a labour of love. We love to do it, and we will keep doing it. And we hope to be able to help you in 2022. And as always, if you'd like to make an appointment to see either Nicole or myself or anyone else in the New Life team, have a look at the appointments page in newlifeivf.com.au. You can make the appointments online. You don't need to call anyone, and it's all very convenient for you. So I hope you enjoy the evening. Thanks once again, and we'll see you next year.